Today we'll discuss the neurology, and first I will discuss how we will examine the patient. Then we'll discuss the common station of what you will encounter in the exam. The first thing is that neurology actually it's a big topic. So if I want to tell everything in one day, it will not possible. So for neurology, we'll use another day, and we'll discuss half portion today, and then we'll discuss the other portion in another day, because it's a very big topic. So at first, when we go to the exam, just at first we'll sit in the outside, and in total in neurology, I have a 10 minutes in one station, like in the other clinicals. And when we enter into the room, the time counts. So first of all, what I need to do, I will wash my hand in every station. So as usual, I will wash my hand. Then I will go to the patient. Most important thing is that sometimes you will found the hand wash easily. It will be in the examiner's hand most of the time. But sometimes you need to go to the table and wash your hand. After that, what your main aim is to look at the instruction. So what's happened most of the time, just you go, you know that because before instruction, the examiners say that you have just examiner will introduce you with you. Just he will say, "Hello, I am Dr. Rahman. I am one of the examiner, and he is one of my colleague. He is also one of the examiner. In this station, I will lead, and he will observe you. Okay? Just in two station, one by one examiner will lead in one station, and then another examiner will lead in the another station. So at first, the examiner will just say that this gentleman is having some problem. Just examine the lower limb, or examine the upper limb, or examine the neurological. So my first aim is to identify the problem or read the instruction carefully, because in the instruction I will get some clue. Okay. Like just someone time you will found that this gentleman has some history of fall. Please examine the patient. This gentleman has difficulty in walking. Please examine the patient. This gentleman has difficulty in writing. Please examine the patient. This indicate that this gentleman is having Parkinson disease. So you will do the examination of the Parkinson disease. Okay. In some station, you will find that this gentleman has some walking difficulty. Please examine the lower limb. This is a very specific instruction. Sometimes you will find this gentleman has some problem in the pumping or in the some hand problem. Please examine the upper limb. So this is a very specific. So most of the time, the instruction is atypical for the Parkinson disease. So if you ask me what is the most common station in the neurology, so that's the number one station is the spastic paraparesis. So it is the most common station. Spastic paraparesis. Say every one of the three will get this spastic paraparesis. Again, the next most common station. So if you say again, that is again spastic paraparesis. After that, you will find the station that is flaccid paraparesis. So spastic paraparesis, then flaccid paraparesis. After that, you will find another station like Parkinson disease. So this is the most three common station. And again, other station for examination is cranial nerve palsy. Then cranial nerve palsy. You will find also acute stroke there. The form of you have been asked to examine the lower limb. Then when you observe the patient, you will find that on inspection his upper limb is flexed posture. And when you examine the patient, you will find there is a spastic monoparesis. So patient comes with spastic monoparesis, and in the upper limb, I will get some finding that confirm that this gentleman is hemiparesis. So acute stroke sometimes comes in the exam. And in case of cranial nerve palsy, most of the time we will found the homonymous hemianopia. Most of the time it will be right or left homonymous hemianopia. And very rarely we will found that 7 cranial nerve palsy. So right or left homonemer semicopia or 7 cranial nerve palsy. Last of all is myopathy. Myopathy rarely comes in the exam. Rarely comes in the exam. But we have to know the point of the myopathy, how we will examine, and what are the most common myopathy comes in the exam. Okay. Among those 6 stations, most common is these two: plastic paraparesis and flaccid paraparesis. And cerebellar syndrome, regarding the cerebellar syndrome usually does not comes in the exam. So our first aim, we have to be very very specific regarding the spastic paraparesis and flaccid paraparesis. We have to learn this by heart. Now I will tell you what is the exam sequence. So as usual, you know that it is a 10-minute station, 6 minutes in the exam and 4 minutes for with the examiner. So 6 minutes with the patient and then 4 minutes in the examiner. So at first, what we will do, I will wash my hand, then I will read the instruction, then I will start my examination. So what I will do first, at first I will do inspection. So first I will do the inspection. In the inspection, in like every station, I have two options. At first I will see the patient and see the surroundings. So I will see the patient and see the surrounding. And regarding the patient, so regarding the patient, what I will see, I will see the patient in a posture, patient posture, in it. Sorry, before doing the inspection, what I will do, I will expose the patient. So, what I will do, I will expose the patient. So, in case of the exposure, for the exposure, each patient may be male or female. So, if the patient is female, so most of the time there will be another female colleague to expose the patient. In case of the lower limb examination, so lower limb examination, at first I will ask the I will go and then I will say, hello, I'm Dr. Rahman, I'm one of the doctor of this clinic. I have been asked to examine you. Is that okay with you? Is good. Do you have any pain anywhere in your body? No. If you have any pain or problem, please let me know. I will be gentle. Then I will go to, sir, I want to expose this patient. So in case of the female, there will be a female attendant. Just I will say the female attendant, I want to expose this patient for mid-thigh to play. So patient, this female attendant will prepare the patient. And in case of the male, so I will ask the patient, can I pull up your trouser, please? Then I will pull up the trouser up to the mid-thigh. So in case of the female, if I am a female and if the patient is also female, and if there is a female candidate, then don't need to do this by your hand. Just ask the female colleague or female attendant, just I want to expose the patient from mid-thigh. Then she will expose the patient. Okay. Now I will see the patient and I will see the surrounding at the same time. In the surrounding, I will see any walking aid. It may be a wheelchair or any specialized shoe. Specialized shoe usually for peripheral neuropathy. And in case of the wheelchair, indicate this gentleman has spastic paraparesis, or even patient may have any neurological problem that he cannot walk. So what I will see, I will examine, is there any wheelchair present or not, or any walking, or any special shoe for this patient. Now I will look at the patient. In patient, I will see the patient leg. In case of the lower limb, I will see the patient leg. What I will see any tremor, any wasting, any scar, or abnormal limb posture. Okay. So any wasting, any scar or abnormal limb posture. So then I will going to palpate this patient. So this is the inspection. So before inspection, I will expose. Then what I will do, I will do the inspection. For the inspection, at first I will see the surroundings just at a glance. Then I will see the patient. Any wasting, any scar, abnormal limb posture. And what I will do here, I will just lift the patient limb to see the heel, under surface of the heel, because it may be some hidden ulcer there. So both I will see the both it properly. Now I will do the palpation. And in the inspection, there is another thing, what is called fasciculation. I will start to doing this. Okay. Then what I will do, I will tap over the thigh or over the calf muscle to see the fasciculation. So I will tap over the thigh or calf muscle to see the fasciculation. So after tapping, just I will observe for 10 or 15 seconds to see any fasciculation or not. Most of the time, I will not find any fasciculation. Now, what I will do, I will check the tone. So I have done the inspection. Now I will check the patient tone. Regarding the tone, usually we can see the tone in three ways. We can see the tone in three ways. Number one is, at first, I will hold the patient knee joint and try to pull up the patient, pull up the leg. I will hold the knee joint and try to pull up. I will hold the knee joint and try to pull up the leg. So if the patient's legs is spastic, then whole leg will be raised. Okay, whole leg will be raised. I cannot bend the knee easily. And if the patient limb is flaccid, then it will be bent easily. So from there, I can only get an idea, that it is plastic or facet. So another thing is the rolling. So side to side rolling. So if I do side to side rolling, then I can say it is plastic or facet. Another way is movement. I can do the passive movement. Passive movement, I will hold just below the knee. At the same time, I will hold the patient figure, and I will my aim to flex both the hip, both the knee, and both the ankle same time. So for that, so in that case, I will assume it is plastic or flaccid. So I will do this in the both right and left leg to identify it is plastic or flaccid. So we will see the tone in three ways. Number one, what I will do, I will hold the knee joint and try to keep up the leg. So if the patient leg is plastic, then whole leg will be raised. If it is flaccid, it is a fall down. Whole leg will not be raised. Then I will do the rolling, and then lastly I will do the movement. That is passive movement. Now what I will check the power. So what I will check the power. To see the power, at first what I will do, I will ask the patient, raise your leg without bending your knee and don't let me push it down. So raise your leg without bending your knee and don't let me push it down. Raise your leg without bending your knee and don't let me push it down.
Recording in progress.
Then I will do it both the right and left side to get some idea is there any weakness present or not. Or if someone wants to say the weakness in MRC grade, then I can do it. But it will not give any specific idea to me. Then what I will do, I will check the thigh muscle at first. So I will check the thigh muscle. For that reason, I will ask the patient, push your thigh up and don't let me push it down. So I will place my hand over the thigh and ask the patient, push your thigh up, don't let me push it down. Now I will now I will place my hand just below the thigh and say, please push it down, push down. Okay, so I have examined the patient thigh up and thigh down. Now I will check the patient. I will ask the patient knee to bend. So I will ask the patient knee to bend, and I will place my finger over both the lateral aspect. Okay, so I have examined the hip joint, that is flexion and extension power, and now I am going to check the abduction and adduction. So I will flex both of the knee joint, and then I will place my hand beside lateral aspect of both knee joint, and I will ask the patient, I will also push my hand or try to separate your knee. Don't let me close it. So push my hand or try to separate your knee. Don't let me close it. Okay. Then by this way, I can check the abduction power. Now I will check the adduction power. Again, I will place over the medial aspects and say push in my hand or try to close your knee. Don't let me separate. So I have checked the thigh. So both flexion, extension, and abduction and adduction. Now I will check the knee joint. So just patient leg will be flexed, and I will just hold the patient ankle. I will ask the patient, please pull your legs towards your buttock. I will say, just pull your legs towards your buttock. Okay? Then I will check the knee flexion. Now I will place my finger in the front of the leg and say, push your leg down. Push your leg down. So I will say extension of the knee joint. So I have seen the flexion and extension of the knee joint. Now I will check the ankle joint. To see the ankle joint, I will just place my hand over the finger or the toes, and then I will ask the patient to push me down. And I will again place my hand over the dorsum of the toes and ask the patient to pull me up. Okay? So in this way, I will examine the patient power. Now I will check the patient reflex. In case of the reflex, before doing the reflex, I always say, look, this is a hammer. This is made of rubber. I will tap it different parts of your leg. Don't worry, it will not be painful. If you feel any pain, let me know. Then I will check the knee jerk, ankle jerk. So before doing reflex, I will say, look, this is a hammer. This is made of rubber. So I will tap it different parts of your leg. It will not be painful. If you feel pain, let me know. Okay, then I will check the knee jerk. Then I will check the ankle jerk. Now I will check the plantar response. To see the plantar reflex, at first again I will do some orientation. I will found there is a stick with sharp head. I will pick up the stick and I will say, look, this is a stick. So I'm going to scratch in your sole. It will not be painful. If you feel any pain, let me know. Okay. Then I will see the plantar response. Okay. So again, before plantar response, I'll say, look, this is a stick. I'm going to scratch in your sole by this stick. If you feel any pain, let me know. Okay. So by this way, I will check the reflex. Now, what I will do, I will check the coordination. Okay. So I will check the coordination. To see the coordination, I will ask the, please place your heel over the knee and drag it down to the ankle. Place your heel over the knee and drag it down the ankle. Then I will say, just do it in the other side. So in this way, I will see the coordination. After that, I will check the sensation. For the sensation, usually there is a pain sensation, there is a touch, and dorsal column. To see the dorsal column, usually you can see the vibration or position. See, if I think that I have enough time, then I will do all of that. But if I think that I don't have enough time, then I will do one from them. In this case, I will check the pain sensation. Then in case of the another way, we will check the vibration. From the dorsal column, we will check the vibration. And from the anterolateral column, we will check the pain. So I will take the neuro trip. To see the pain, there is usually a neuro trip there. So I will look, this is a neuro tip. So I'm going to sketch it over your chest. In patient, I will not touch this neuro tip to the face. It is always in the chest. Okay. Because in case of the vibration, you can place the tuning fork over the forehead. But in case of the neuro tip, we will always in the chest. So look, I'm going to scratch it over your chest. Then case of the female, we have to be careful. Then I will touch the neuropin. Can you feel it? The patient will say, yes, I can feel. Okay, I'm going to touch it over different parts of your leg. If you feel, please let me know. Okay. Now I will ask the patient to close the eye. If we don't ask the patient to close the eye, it's also okay, because we always trust the patient. But the thing is that sometimes patient do misperception. When I go to the patient leg, patient may say yes. So for that reason, what I will do, I will ask the patient to close your eye. Then I will ask the patient to please close your eye. Then I will touch the neurotip, the different parts of the leg. If the patient say yes, then I will say the opposite of yes, and then yes, yes. Then after 2 or 3 times, I will easy similar to your chest. The patient will say yes most of the time. Okay. Then if I want to the touch, then I will do it by cotton stick, by the same way. Now from the dorsal column, I will check the vibration test. So look, this is a tuning fork. I will just place the tuning fork. First I will take the tuning fork, and I will I will to make the tuning fork to buzzing by a scratch or by holding the upper tip. Then I will place the tuning fork. Look, this is a tuning fork. I'm placing the tuning fork in your chest. After placing, I will say, can you feel the buzziness of this tuning fork? Patient will say, yes, I'm feeling it is buzzing. Okay. I will place the tuning fork over your legs. Then please close your eye. Then patient will close the eye. I will place the tuning fork over the index finger. Oh, so over the great toe. Then can you feel it? Yes. Then I will do it in the other side. Can you feel it? Yes. So in this way, I will check the sensation of the dorsal column. That is vibration sense. So if I want, I can also check the position change. So I will do it in the grade 2 also. So I will hold the grade 2, then look, this is up and this is down. Or I can say only it does not necessary to lift the leg, because it's a positional sense. So look, this is a down, this is a up. We'll always hold the finger from the side to side. So then please close your eye. Where it is down or up? The patient will say it is up or down. So this is the way I will do the examination. So what I done? As far I do the inspection, and then I have checked the tone, the power, reflex, and I have also seen the coordination and sensation. That is pain, touch, and dorsal column, vibration sense, position sense. If I don't have enough time, I will say only the pain by neurotips and dorsal column from vibration by the tuning fork. Okay. So what I miss here? I miss the clonus test. If we find that patient is actually, when we see the tone from my movement, then we will observe the tone clonus. In case of the patients, usually if you see the ankle clonus, that is sufficient. So when we see there is a spastic, and when we see the movement by movement, tone by the movement, that is why then we will observe the clonus automatically. So we don't need to see the patellar clonus. So we only see the ankle clonus. Okay. So what we have done, we have done the motor system, and we have also done the sensory system examination. Okay. So, okay. So anyone have any question up to this regarding examination?
Yes, sir. Regarding sensory system, you said pinprick only is sufficient, or soft cotton wool also we have to do?
Yes, it depends on the time. So if you take enough time in the motor system examination, so it is better to do the one from one. Because if you think that everything is going to the spastic paraparesis with definite sensory level, then you have to go to the back. So if you think that time will not allow you to see the back, then just will do one from the one. From the anterior column, for you only the pain sensation. From the dorsal column, just choose the vibration sensation, because it is more reproducible.
Doctor, why do we need to do the cotton wool? What's the significance? What will it tell us?
Sorry?
When we're doing the cotton wool through touch, what will it add to
Yes,
our
yes.
findings?
Good question. It does not add anything new in our findings. Okay, so now I'm going to tell actually what we have observed in these findings. So what I have observed already. Actually, in any case, with the lower limb examination, our aim was to see some motor finding, to see some sensory finding, and in between motor and sensory, I will check the cerebellar. So motor finding, sensory finding, and cerebellar. So what we have, we examine the motor system. Okay, so motor system, that is uh, just inspection. Then we have checked the tone, power, reflex. Okay, so inspection, tone, power, reflex. So those are actually the motor system finding. So motor system finding actually tell us whether the lesion is upper motor neural lesion or lower motor neural lesion, or the as a general cause, what is the type of the lesion. Now, after that, we examine the sensory system. That is, we have examined the anterior column and also the dorsal column. So, if anyone has any sensory lesion, then we can say actually where is the lesion. Okay, if it is sensory system is the dermatomal distribution, then we know that this is a peripheral nerve lesion. If the sensory system is affecting both sides symmetrical, so we know this is a spinal cord lesion. So sensory system examination actually tell us where is the lesion. So at first we will do the motor system examination. So motor system examination actually tell upper motor neural lesion or it is a lower motor neural lesion. Then we have examined the sensory system. Sensory system examination will tell us where is the lesion. In between motor and sensory, when we examine the coordination, actually we have examined the cerebellar system at that point. So we have examined the cerebellar at that time. When you see the coordination. Now, when we say the finding, we have to say all those things in a separate manner. So that it will be a meaningful one to point a diagnosis. So, what we have examined, motor system again, sensory system, and cerebellar. So we will say all those things in three different parts. So now I'm going to the case that is spastic paraparesis. So it's a very common case, spastic paraparesis. See, in case of the spastic paraparesis, case of the spastic paraparesis. So this is the spastic paraparesis. Always is a motor finding, which is a output of the motor system examination. So when we say the spastic paraparesis, always we have to say the sensory along with that. So spastic paraparesis is not any finding without any sensory. So when we say there is a spastic paraparesis, so we will not say that. We'll just say spastic paraparesis with definite sensory loss, spastic paraparesis with anterior column lesion, or spastic paraparesis with dorsal column lesion, or spastic paraparesis without any sensory loss. So I will say spastic paraparesis in various ways. First of all, spastic paraparesis without any sensory loss, without sensory loss. So what I will say, just I will say on examination of this gentleman. So I have examined the patient, the gentleman. I will say on examination of this gentleman. At first, I will say, is there any wasting, scar, fasciculation, abnormal lip posture, I'll see the surrounding, any walking aid on a specialized shoe or not. So examination of this gentleman, but most of the time, if it is painful positive, I will not find anything. Just I will go to the second part. Okay? So on examination of this gentleman, inspection finding. If there is no inspection finding, I will go to the next. Okay. There is a symmetrical weakness of the both legs. Okay. So there is a symmetrical weakness of the both legs. After that, actually, here I will stop and I will say something where I have to, in this weakness, I will differentiate. In this weakness is upper motor neural lesion or lower motor neural lesion or any myopathy. Okay. So how we will differentiate? In case of the upper motor neural lesions, if you see the stroke patient, what's happened? Usually leg is straight. So there is a straight leg. So that indicates there is a weakness of the flexor muscle. So in case of the upper motor neural lesion, what we found? Found its leg is straight. So there is a weakness of the flexor muscle. Okay. And as there it is a neuropathy, so there is a distally will be more weak than proximal. So more distal weakness. So more distal weakness. And as well as I have found there is a more flexor involvement. Okay. And in case of the myopathy, actually what's happened? In any myopathic patient, actually what we say, there is a frog-like distribution that indicates patient cannot adduct his leg. Okay. Here we found the adductor weakness. So patient cannot adduct. Here the opposite is occur. That is abductor weakness. So abductor weakness. So in case of the lower motor neural lesion, again this is the same flexor type of weakness, more distal weakness, and as well as abductor weakness. We just don't need to say everything. Just we will say flexor or distal or proximal. Okay. Sometimes we may confuse it is abductor or adductor. If we found something specific about the myopathy, then we'll say this is a adductor type. Yes. Okay. So again, I will say just on examination of the gentleman, there is a symmetrical bilateral weakness of the both leg. Okay. Where distally is the more weak than proximal, and flexor are more weak than extensor, and abductor, if we want to say, abductor is more weak than flexor. All this finding indicate this is a neuropathical, this weakness due to neuropathy. Okay. And there is also hypertonia, as there is a, I'm saying going to say the spastic paraparesis finding. Then, so there is also hypertonia, hyperreflexia, and positive pyramidal sign. If I find the clonus, I will say along with clonus. Okay. And coordination examination is normal, or coordination cannot be assessed due to weakness. Again, sensory system examination indicates all modalities of sensation is intact. So my diagnosis, this is a case of spastic paraparesis with intact sensory level. Okay. So in my, I am going to say it again. So my first case is this is the case of spastic paraparesis without any sensory loss. So what I will say, on examination of this gentleman, I found that if there any scar, fasciculation, or osteal, I'll say it. If no, I go to the straight. There is a symmetrical weakness of the both lower leg, where distal is the more weak than the proximal, and flexor are more weak than the extensor. This indicates it is a neurological weakness. Okay. Again, and there is also hypertonia, hyperreflexia, and positive pyramidal sign, along with tonus. Okay. Coordination examination cannot be assessed due to this. And sensory system examination of this gentleman reveals all modalities of sensation is intact. So this is a so my diagnosis, I will say here only the clinical diagnosis at first. So my clinical diagnosis, this is a case of spastic paraparesis without sensory loss. So this is the case of spastic paraparesis without sensory loss. So this is a case of spastic paraparesis without any sensory loss. Okay. Now examiner will ask the question actually, uh, what is the cause? Then go to the. I'm going to say it again. So my first case is spastic paraparesis without any sensory loss. So on examination of this gentleman, there is a walking aid or there is a wheelchair. And there is a symmetrical weakness of the both leg, where distal is the more weak than proximal and flexor are more weak than extensor. Okay. There is also hyperreflexia and hypertonia and positive pyramidal sign along with the clonus if present. Apart from and coordination of these gentlemen is cannot assess properly due to weakness. And sensory system of examination of the gentleman reveals all modalities of sensation is intact. So my clinical diagnosis is a case of spastic paraparesis without any sensory loss. Then if we see the if we see the mark sheet, then we'll find that marks is distributed in differential diagnosis. So in every case, we have to know the clinical diagnosis as well as differential diagnosis. Then appropriate management plan. And so most of the time, if we find the findings in a case, usually we'll secure more than 15 marks. Then they will ask the question actually, what is your clinical diagnosis? What is the differential diagnosis? How we are going to investigate this patient and how we are going to manage this patient? They can ask many other questions apart from this, but most your mark is distributed in those 4 questions. So what is your clinical diagnosis? Spastic paraparesis without any sensory loss. Then I will ask the differential diagnosis or the cause. Here they will ask the cause. So if you see the spastic paraparesis in then the examiner will say the cause. The first cause is most of the time will found this is a cause of cause may be vary from country. Most of the time this is a case of, I will say that's motor neuron disease, but they had usually multiple sclerosis, and in case of the parasagittal meningioma, recurrent stroke or multiple stroke. And another thing is spinal cord hereditary spastic paraparesis and tropical spastic paraparesis. So those are the common cause, that is spastic paraparesis without any sensory loss. So again, this is motor neuron disease, multiple sclerosis, parasagittal meningioma, recurrent stroke, hereditary spastic paraparesis, and tropical spastic paraparesis. So those are the common causes. Yes, sometimes in case of tropical spastic, we can find the sensory sign, but not always. So I will say those this multiple motor neuron disease, MS, parasagittal meningioma, recurrent stroke, hereditary spastic paraparesis, tropical spastic paraparesis. Okay. So this is the then examiner will ask the question. So our main aim here is MND, MS, parasagittal meningioma, and recurrent stroke. Now I again go back to the examination of the patient, because in every time if I get some time, I'll do some additional thing. Okay. So now think, if any patient comes with the spastic paraparesis without any sensory sense, so what I will do next? Next, I will do check the back. Okay. Why back? It's as usual. It's a usual procedure. So I will check the back first. Then yes, I have another time. I will go to the upper lip. I will go to the upper lip only to check 2 or 3 sides. Just I can check the jar only. Okay. Or tone. Chest. Then I will check the patient tongue to see any fasciculation. Okay. So so again, examiner asked, or there is a direction then to examine the patient lower limb. But if I have enough time, then I will go up. Okay. So this up is only depends on the cause. So the lower limb examination, I find there is a spastic paraparesis without any sensory loss. I will immediately check the back. I will roll the patient. I will check the back. Okay. And another interesting thing is that if any patient is MND, comes in the exam, we'll found there is some weakness, only the weakness. And again, in another patient, most of the patient here will not comes with will come with some form of weakness, not plasias. They comes with the weakness. So I'm saying this weakness, and MND patient comes with the weakness. Okay. So just I will ask the patient to roll. The patient will roll, and I will check the patient back. Then I will go to the patient upper limb. In case of the upper limb, just I will say one or two signs. Just I will say the reflex, or I will say the tone. Just I am going to check the patient tongue. There are a lot of things to do, but I will try to do this. So in case of the MND, I can get some clue. Okay. So now examiner will ask the question, what investigation you want to do. In case of the investigation, as is my first, I think it's maybe spinal cord problem. And here my first diagnosis is MND. It's actually clinical diagnosis. So we can do the EMG here. And in case of the spinal cord, I will do MRI of the spinal cord. Here is also recurrent stroke. So I can check the patient MRI of the brain also. And for the MS, I will do CSF test or unipolar band. I can do the visual evok potential. Okay. So again, for the hereditary spastic paraparesis, I can do some form of I can take the family history. So if you say the investigation, so what investigation you will do? Just look at the cause and say one for each. You can say in the other way that first I will do some basic investigation like every patient, but here it's totally different. So better to say to see the MND is mainly the clinical diagnosis. Just I will exclude the other thing. If anyone say the what is the most common differential diagnosis of MND, that is cervical myeloid. For that reason, you will do the if you do the MRI of the spinal cord or brain. So actually, we will exclude recurrent stroke or any brain spinal cord pathology. And in case then I will say that for the multiple sclerosis, I will do the CSF to see the unipolar band. I will do the visual evok potential. For MND, I can do the EMG. For hereditary, I will take the family history. So this is the case regarding. And now, lastly, will be how we do manage this patient. For this management, actually, I have I will say two. So some general management, that is patient education, counseling, formation of the multidisciplinary team that involve my consultant, social worker, occupational health worker, physiotherapist, neurologist. So regarding the investigation, just I will say one for each. Okay, I will say just MND is mainly clinical diagnosis, so I have to exclude the differential. For the number one differential for the MND is cervical myeloid. Okay, and I will do the MRI of the spinal cord and brain. If we do the MRI of the brain, just I will exclude the parasitical meningioma recurrent stroke, as well as in case of the MS, I will find some finding of the brain. And another thing is then I will do the CSF study for the oligogonal brain. And for the MS, I can check the visual evok potential. And again, for the MND, I can also do the EMG. And for hereditary spastic paraparesis, just I can do the some genetic test, family history. So those are the investigation. Last question is how will you manage this patient? So manage. Regarding the management, in all types, in all neurology, there will be some general management and some specific. So general management, just I will do the patient education, counseling, explanation of the disease, formation of the multidisciplinary team. Okay, that include always my consultant here, neurologist, because I am saying to the examiner, social worker, occupational health therapist, or occupational health officer. Okay, and here this is the general management. Now I will say some specific management. Okay, sorry, another thing is a physiotherapist. So specific management actually differ from patient disease to disease. Here, examiner may ask some question regarding any specific management. Okay, so here examiner may ask some question regarding the specific management. Who asks the question, what is the management in case of hereditary paraparesis? Actually, no management, only the physiotherapy. Okay, what is the management in MS? So at that time, it actually differs. MND, no management. You can give riluzole, but increase the patient survival up to 3 months. Okay. So that time actually vary, and a follow-up of the patient actually is vary. But I will say the general management as well as specific. In that case, examiner will ask question regarding from anything. Okay. Okay. So this is the spastic paraparesis with without any sensory sign. Now we will discuss the again spastic paraparesis. Now we will discuss spastic paraparesis with loss of sensation. Okay. If you say the finding again, so on examination of this gentleman, there is a weakness of the both legs. Second, so on examination of this gentleman, if you feel any scar, they will say the scar in wasting or something, or I will say directly. On examination of this gentleman, there is a symmetrical weakness of the both legs, where distal is more weak than proximal and flexor are more weak than extensor. There is also hypertonia and hyperreflexion, and there is also a positive pyramidal tract sign along with clonus. Cerebellar system examination reveals, or sorry, here usually in this case, spastic paraparesis with definite sensory sign will not find anything. Will most of the time we found there is a profound weakness. So cerebellar system examination is not possible, or coordination is not possible to see as there is a weakness. Sensory system examination reveals all modalities of sensation is absent up to the level of umbilicus, or up to the level of thoracic 10, or up to the level of thoracic 8, that is midway between the G5 sternum and umbilicus, or up to the level of the G5 sternum, that is thoracic 6. So I will say this way. So then I will say this. So my clinical diagnosis, this is the case of spastic paraparesis with definitive sensory sign, or spastic paraparesis with loss of all modality of sensation up to the level of this, or spastic paraparesis with signs of complete cord transection. So I will say this is a spastic paraparesis with loss of all sensation, or spastic paraparesis with complete cord transection, or spastic paraparesis with definitive sensory lesion. So what will be the differential diagnosis? So in case of spastic paraparesis with definitive sensory lesion, our main differential diagnosis is 4. Mainly, if you remember the 4 T, then it will be easy. That it is maybe due to trauma, it may be due to transverse myelitis, it may be due to tumor, or it may be due to TB. Okay, so this is the 4 T. But before that, what we will say? Any cause of dorsal myelopathy. Dorsal myelopathy. What are the cause of dorsal myelopathy here? This. So again, on examination of the gentleman, there is a weakness of the both leg where distal is more weak than proximal, then flexor are more weak than extensor. And there is also hypertonia, hyperreflexia, and bilateral upgoing plantar response. Okay? And on examination, coordination examination is not assessed as there is a profound weakness. Sensory system examination reveals all modalities of sensation is absent up to the level of umbilicus. So my diagnosis, this is a case of spastic paraparesis with loss of all modalities sensation up to the level of umbilicus. Then we will say, what will be the cause? Any cause of dorsal myelopathy. Like it may be any trauma, or it may be transverse myelitis, it may be tumor, or tuberculosis. Okay. Sometimes we may get this gentleman has some catheter. So if there is a catheter, then also there is a catheter in situ. So along with that, I can get the catheters. If I get catheter, I will say this there is a catheter in situ. Okay. Sometimes it's also possible that the finding is not symmetrical as we think. Sometimes you will find that because it depends. It depends. If it is transverse myelopathy, then we prepare all the full picture. If it is tuberculosis, it depends on the extent of the tuberculosis, how it involves. And as well as in case of tumor, if it is intramedullary or extramedullary, there will be some difference. Okay. But in case of the cases clinical station, they will put the case where there is obvious findings. Usually, most of the case here is as transverse myelitis or any trauma, spinal injury, and now it is operated or anything have done, but there is still weakness and leg is not improved. And every time he comes in the X-ray, say it's the most common thing. So again, if we say that what is the how we going to investigate this patient, regarding the investigation, I will say the MRI of the dorsal spine. I will say the MRI of the dorsal spine. Yes, I will do the other investigations, but first of all, MRI of the dorsal spine. Then I can specify the investigation. If I find in the MRI there is a tumor, then I will do the CT or guided FNAC. If I case in the MRI there is a possibility of TB, that means if there is a discitis, there is a loss of compression fracture or collapse, there is a vertebral collapse, there is a paravertebral abscess, which suggests the tuberculosis. Then I will do the other thing, that is chest X-rays, put on for MPs, put on for gene expert, MT test. Then I will do the test. But most of the time, I will say I will do the MRI of the dorsal spine. Okay. Now regarding they will say how will you manage? Then again, management, I will do the general management and specific. For the general management, that includes patient education, counseling, explanation of the disease, formation of the multidisciplinary team that involve my consultant, okay, neuro nerve doctor or a neurologist, physiotherapist, social worker, occupational health care therapist. And here the patient is it's not catheter or so I will say that I will take the bowel care, I will take the skin care, I will do the physiotherapy. And specific management actually depends on the cause. If there is TB, anti-tumor chemotherapy, tumor, do the surgery. Transverse myelitis, if there is acute transverse myelitis, I will start steroid. So in this way, I will see the management. So number 2 cases, spastic paraparesis with loss of all modality sensation. Okay. Now I will go to the another case, that is again spastic paraparesis. So spastic paraparesis. Hello, any question?
Sir, can I ask? Sir,
yes.
You said spastic with loss of sensation. What about anterior spinal artery occlusion?
Okay, wait for this time. Okay, so now I will say that spastic paraparesis with anterior coordination. So this is our third case, spastic paraparesis and anterior. Here, while we do the examination, at first I will find that there is a spastic paraparesis in the motor system examination. Sensory system examination is not done. Coordination is not assessed due to weakness. And sensory system examination, there is a on loss of pain plus touch. But when we check the posterior column, that is vibration plus position, I will found that is intact. So this indicates there is a only interior correlation. So this indicates there is a only interior correlation. So I will say this on examination of this gentleman, there is a weakness of the both leg, symmetrical weakness of the both lower limb, where distal is more weak than proximal, and flexor are more weak than extensor. And there is also hypertonia, hyperreflexia, and positive pyramidal traction along with conus if present. And coordination is not assessed due to weakness, and sensory system examination reveals there is a loss of pain and touch sensation with intact vibration and position sense. So there is a loss of pain and touch with intact vibration and position sense. So again, so my clinical diagnosis is a case of spastic paraparesis with anterior coordination or anterior cord syndrome. Okay. Now, they will say what? Okay, so there is a spastic paraparesis with anterior. Okay, so there is a spastic paraparesis with anterior cord syndrome or anterior cord lesion. Look, in the anterior cord lesion, actually, whole of the anterior cord is supplied by the anterior spinal artery, and posterior cord is supplied by the some posterior spinal and sometimes vertebral artery, both. And here the important thing is that if any patient has the spastic paraparesis, they will put in the exam and they will assess the candidate in different way, because here they will put a surrogate, okay, who is also there will be a patient, there will be attendant or surrogate or translator. He will say different thing because he can see the everything. You will only see the motor finding. You can only assess the motor finding. But in case of the sensory finding, you have to depend on the patient, or you have to depend on the surrogate or translator, what he says. Okay. So he says a lot of things. So it's possible in one candidate he will say, I could not find, I don't have any sensation, both anterior column, dorsal column. He can say, yes, in case of pain, yes, I can feel. When I say the vibration, he may say, no, doctor, I don't feel it. Because this surrogate is seeing what you are doing. Okay. So he can say everything. So in this way, he can assess the different patient. Okay. So it's very easy. You may find this in your exam. So spastic paraparesis with anterior column lesion. So this is the most, what is the cause? So it is your clinical diagnosis. What is the cause? Cause is anterior spinal artery occlusion. So the anterior spinal artery occlusion. So vessel may be most common. Most common cause of any vessel obstruction is embolism from the heart. That is embolism. So there is a embolism from the heart, okay, or maybe thrombosis in situ. So there may be thrombosis, and there may be arteritis. That means vasculitis. So those are the cause. So there may be embolism, there may be thrombosis, there may be vasculitis. Anything in this patient, you will check the pulse. If you have atrial fibrillation, that indicates there is an embolism. And in case of the thrombosis, actually thrombosis is a large thing, but if you check any patient with thrombosis, there most of the common cases it is associated with connective tissue disease. That means antiphospholipid syndrome, okay, or maybe congenital. Congenital maybe the protein C, protein S deficiency, protein C or protein S deficiency. So connective tissue disease, which is any myelo or lymphoproliferative disease, paired or nocturnal hematuria. So there are a lot of those, but most common is those. And there is a vasculitis. Again, vasculitis primary or secondary. Secondary is all connective tissue disease, infectious vasculitis, malignancy associated vasculitis, or primary vasculitis. So this, if the examiner asks the question, he will ask the what is your clinical diagnosis. So this is a case of spastic paraparesis with anterior features of anterior cord transection or anterior cord syndrome. So what is your do you have any differential diagnosis for this finding? Yes, it may be due to anterior spinal artery occlusion. So what are the cause? Maybe embolism from the heart source, that is atrial fibrillation, thrombosis. For thrombosis, the most common connective tissue disease, antiphospholipid, congenital, myeloproliferative disease, lymphoproliferative disease, PNH, and vasculitis. Vasculitis again is primary and secondary. So how will you going to manage? Again, general management that include patient education, counseling, explanation of the disease, formation of the multidisciplinary team that involve my consultant, neurologist, occupational healthcare therapist, social worker, physiotherapist, skin care, bowel care, proper nutrition, and specific management depends on the cause. Okay. So he may ask, so what are the common causes of thrombosis? Or he may ask, what are the common causes of embolism? Okay. So actually at that time is differ from question may differ, or examiner asks in a specific question. Now another case, this is a spastic paraparesis with dorsal collaboration. So spastic paraparesis plus dorsal collaboration. Again, when we see the going to examine the patient, we'll find there is a motor system examination, there is a spastic paraparesis. Sensory system examination, then coordination cannot be assessed due to weakness, or coordination may be normal or abnormal. And sensory system examination will tell us there is a okay. Sensory system examination, there will be pain plus touch sensation is intact, but vibration position is absent. So what I will say, on examination of this gentleman, I found that there is weakness of the both their leg, where distal is more weak than proximal, and flexor are more weak than extensor. And there is also hypertonia and hyperreflexia. Okay. With positive Babinski sign or positive pyramidal tract sign. Coordination is not assessed due to weakness, and sensory system examination reveals there is a intact pain and touch sensation, but absent vibration and position sense. Okay. So another interesting thing is that in any case of weakness, when you want to see the coordination, actually it will not be perfect, because a patient has weakness, so he have problem to sustain hold of the ankle. So sometimes it drops down again, he will try to pull it up again, drop down of the ankle. So if any case you think there is a this type of weakness is possible, then we check. You just after the exam, if you have enough time, just check the finger nose test, because cerebellar is specific in the upper limb. You cannot explain or you cannot find the specific cerebellar in the lower limb. Just go to the finger nose test. So this is the hard sign of the cerebellar lesion. Okay, so so this is a case. So what is your clinical diagnosis here? So my clinical diagnosis is a case of spastic paraparesis with dorsal collaboration. So spastic paraparesis with dorsal column lesion. So what may be the cause? So here actually cause differ. Here, what are the common cause? Number one is here in this patient actually spastic paraparesis with dorsal column lesion. It's a, here patient is very much important. Okay, so if anytime when we examine the spastic paraparesis, that coordination, you think there is a possibility of some coordination problem, then sensory section you will find there is a vibration or position sense loss, but pain does temperature is present. Then actually you are dealing with Friedreich ataxia. So, but what are the common differential as a whole? It may be due to subacute combined degeneration, maybe due to Friedreich ataxia, it may be due to multiple sclerosis, it may be due to tabes dorsalis or taboparesis. Okay. Now, in this case, if any patient I check first, I check the motor system, I feel there is a spastic paraparesis. But in between coordination, if you find there is a coordination problem, that indicates cerebellar involvement. When you check the sensation, sensation indicate the dorsal column involvement. Now look all those cases. So what in those specific you get some extra there. In case of the multiple sclerosis, look, this is the only solely upper motor neuron disease. So you will found here spastic paraparesis plus cerebellar problem. So spastic paraparesis with cerebellar problem. Okay. So because this does not involve the lower motor neuron, there is spastic paraparesis with cerebellar problem. Regarding the Friedreich ataxia, there is all problem of neurology is present in Friedreich ataxia. Okay, so there is a spastic paraparesis plus cerebellar problem plus dorsal column problem plus peripheral neuropathy. In case of the peripheral neuropathy, it always starts from the lower end. Okay, and hard side of the peripheral neuropathy is loss of jerk, loss of reflex. That I will loss of ankle reflex usually there. Okay. Now again, if you say the subacute combined degeneration, it also present in various ways. Most commonly, if it is involved to the back, then spastic paraparesis. Think that subacute combined degeneration now affecting the spinal cord. So spastic paraparesis plus I will found peripheral neuropathy, that is loss of ankle jerk. But it may extend to the up, that is may extend to the cerebellum, may produce cerebellar sign. Okay, so many later we will find the cerebellar sign. So if we found there is only spastic paraparesis plus cerebellar sign, that indicates this is a multiple sclerosis. If you found this is a spastic paraparesis plus dorsal column lesion plus loss of jerk, that is ankle jerk, it may be Friedreich ataxia if the age is young, and it may be due to subacute combined degeneration. Differentiation in between two is very much difficult, but you can assume from the other thing. In case of the Friedreich ataxia, actually they have all problems. If you do the fundus, you will find there is a optic atrophy. If you see the heart, there is some heart problem. So there will be all problem there. Okay? But so those two is one another differential diagnosis. Another thing is that spastic subacute combined degeneration is monophasic. That is, all things going progressively up. But and phagic ataxia is also monophasic, but MS is actually sometimes up and down, sometimes up and down. So those are the difference from the others. But subacute congenitalization and phagic, case of the phagic, as it is autosomal disease, hereditary recessive disease. So usually all problems start from the beginning. Okay, so all problems start from the beginning. But in case of second or subacute combined generation, I will find progressive sign. Patient is now spastic paraparesis. Now patient is loss of ankle reflex, and another few days later when it go up and extend, it cause cerebral problem. Okay. So what I will say that there's a differential diagnosis. What is there as a mass? There is a differential diagnosis is taboparesis, subacute combined degeneration, phagic ataxia, multiple sclerosis. Most of the time, what if any patient of phagic ataxia present in the hospital, he will come in your exam. So, phagic ataxia patient, how I will recognize? It is a young patient will be young. Patient will be young. Usually, I will found the patient is 16 or 16 years, but it's very unusual vitamin B12 deficiency at this age. So, in case of second, most of the time patient is older patient. But what I will say as a differential diagnosis, I will exclude it by doing investigation. So regarding the then how we going to investigate the patient? Again, I will start from the MRI of the spinal cord. Then, as there is a peripheral nerve involvement, what I will do? NCS and ENG. In any case of peripheral nerve involvement, I will do NCS and ENG. Vitamin B, MS is there. So again, MRI of the brain will give some clue. CSF will give CSF for oligoclonal band, visual evoked potential for the MS. Phagic ataxia, I have to do optic fundal photograph to see the optic disc, fundal photograph. Then I will do ECG, chest X-ray, echo to see the cardiomyopathy. And lastly, I will do the genetic test to confirm my diagnosis. This gentleman is also some diabetics mellitus. So I'll do blood glucose fasting, 2 hours of your blood fast, including HbA1c. So, I will do a lot of investigation here. Lastly, management. Again, general and specific patient education, counseling, formation of the explanation of the disease, formation of the multidisciplinary team that involve my consultant, social worker, occupational health care therapist, lots of people. Then specific management depends on the cause. If it is subacute continuous degeneration, then I will do the test, vitamin B12 placement. If it is a phagic ataxia, actually I will do the symptomatic management for some drug for spasticity, cerebral problem. And even if it is MS, I'll have to check other thing, either to start biologics or not. So that's the difference from the costumes. So this is the case of spastic paraparesis. Okay. So now something about the spastic monoparesis. So sometimes we will found there is a spastic monoparesis. So when I examine the patient, I will found there is a spastic monoparesis. So spastic monoparesis. I will found there is a spastic monoparesis. Immediately, what I will check the patient upper. So spastic monoparesis patient. Then what I will check, I will again check the patient back first. I think that I have examined the patient earlier. I have another 2 minutes. Just what I will do, I will check the patient back. Check the patient back. Then I will go the upper limb. Upper limb on inspection of what I will found, if it is most of the time, the spastic monoparesis patient will be acute stroke patient. That is patient of history of acute stroke. Patient is now on getting the physiotherapy, comes hospital to get the physiotherapy. Now patient in the examiner hall. Because in case of acute stroke, it's a devastating patient. We will not put the patient of acute stroke. We will find everything of the chronic stroke. So patient of stroke, so we'll check the upper limb. There is the flex posture of the upper limb. Okay, typical. And then we check the what we'll do in upper limb. We will do the only one or two exam. Only tone, power, only tone or power. Okay, or if we think we can check the Hoffman sign here. Check. If we check, we can check the Hoffman sign. So in case of spastic monoparesis, if I first of all I will do the examination of the motor system, then I will examine the sensory system of the lower limb. Then I will check the back. I will check the back every time because it may be due to Brown-Sequard syndrome, maybe due to trauma or anything. Because this trauma only involves that track, one side. So anything may happen in the back due to trauma. Okay. Then I will go to the up. I can check that there is a flex posture. I have seen already there is a flex posture of the upper limb. Just I will check the tone and power. uh, if there is time allowed, I can check the reflex and Hoffman sign. Okay. Then what I will do, I will go if time allowed. Then I will go to the eye, or I will go to the seventh one. But usually time will not permit me. So this is a case of spastic monoparesis. In case of the spastic monoparesis, what will be my differential? So my clinical diagnosis, this is the case of spastic monoparesis without any sensory loss. So I will, in every case, I will say the finding of motor system along with the sensory system. Just like this is the case of atrial fibrillation with fast ventricular rate, atrial fibrillation with slow ventricular rate, because it is a two terms comes simultaneously. Here, spastic or flaccid, that is motor system, always comes with a sensory finding. So my clinical diagnosis is as spastic monoparesis plus without any sensory loss. So without any sensory losses. So what is your diagnosis? Number one again is acute stroke. Sorry, acute stroke. Say, and there will be some. We know there are some differential diagnosis stroke, some structural functional will show everything. So it may be IXOL or brain tumor. It may be MS. Okay. These are the structural. And regarding the functional hypoglycemia, hemiplegic brain conversion, there are a lot of things. But always we say it may be IXOL, it may be MS. Okay. And in case of the spinal cord, it's possible of Brown-Sequard syndrome. But in Brown-Sequard syndrome, there will be one side there will be excessive sensory motor loss, and another side will be sensory loss. Most common cause is trauma. It will not come usually in the exam. So most common cause is stroke. That is IXOL and MS. That is the structural duty of the stroke. Functional usually comes in the exam. But you can say that post-ictal paralysis, hemiplegic migraine, conversion disorder. Okay. So again, now regarding the investigation, what I will do, I will check the brain. When you I will always check the brain. That is MRI of the brain. Again, for this MS, I will check do MRI of the spine, visual evoked potential, CSF for the oligotonal blood. Okay. So this is the spastic paraparesis without any sensory sign. And there is no case regarding spastic paraparesis with sensory sign. So spastic monoparesis with sensory sign. Okay. Now I'm going to move to the spastic flaccid paraparesis. In case of the flaccid paraparesis, it also comes in two ways, with some sensory sign, without some sensory sign. So with sensory finding, number one is without sensory finding. So first we'll say that without sensory finding. So, we know that in case of the flaccid paraparesis, we just again say the same finding. We'll again do the same thing. We'll do the inspection. Here, most of the time, we found some proof. That may be some finding in the leg. There is a wasting, flowing of the finger. So there is a wasting and blowing of the finger. So if I found there is a wasting but blowing of the finger or toes, that indicates a chronic process. So wasting, blowing of the finger or toes indicates chronic process. So and I have said this is a expressive paraparesis without sensory finding. So what will be the on examination of this gentleman? There is a wasting as as well as in case I feel there is a pulling of the finger. There is a weakness of the leg where distally is more weak than proximal and extensor is more weak than flexor. And there is also hypotonia and hyporeflexia. Or if there is no reflex, there is also hypotonia and areflexia. And coordination is intact. And apart from this, sensory system examination reveals all modalities of sensation is intact. So this indicates this from what is your diagnosis. So my clinical diagnosis, this is a case of flaccid paraparesis without any sensory loss. Okay, so my diagnosis, this is a case of flaccid paraparesis without any sensory loss. I can extend the diagnosis. I can say bilateral symmetrical flaccid paraparesis without any sensory loss. Okay, but usually it does not need if I say the paraparesis. So flaccid paraparesis without any sensory loss. Now, what is my differential diagnosis? You say actually this is a very broad differential diagnosis list. So again, flaccid paraparesis with two types, without sensory loss and with sensory loss. So flaccid paraparesis without any sensory loss. So what is it is my clinical diagnosis. Now what is my differential diagnosis, or what may be the cause? Cause maybe number one case is AIDP or GBS. That is acute inflammatory demyelinating neuropathy or GBS. And there is something always related to GBS, that is porphyria, acute intermittent porphyria, and plumboporphyria, that is lead poisoning, acute lead poisoning. That means acute intermittent porphyria, lead poisoning, and again hereditary sensory motor neuropathy. Hereditary sensory motor neuropathy, actually that Charcot-Marie-Tooth disease. It is usually two types, type 1 and type 2. So in one type, I don't know actually which type, forget this. There is only the involvement of the motor system predominantly, and another is involving the sensory system predominantly. Okay, so it may be hereditary sensory motor neuropathy. If it is demyelinating variety, if it will involve the motor system. If it is axonal variety, it will be involve the sensory system. So hereditary sensory motor neuropathy. So sometimes we can say this may be also CIDP, but in most of the CIDP found some sensory sign. So all these are the causes of peripheral nerve. So if you go up, there will be anterior horn cell. There will be a root. So bilateral motor radiculopathy. So motor radiculopathy. Then I will go up. There is an anterior horn cell. Say in anterior horn cell, there is a motor neuron disease. That is a progressive muscular atrophy type, and there is also poliomyelitis. It is not so common. Lastly, if it is acute or patient muscle bulk is intact, I can say there is also myasthenia gravis. Lastly, myopathy, another cause. This is neuromuscular junction problem. And lastly, myopathy, that is myotonic dystrophy. Myotonic dystrophy, but myotonic dystrophy, there is characteristic phases, but maybe some early we can get this fine. So again, this is a case of flaccid paraparesis case of the flaccid paraparesis, it may be with sensory sign. Number 2 is without sensory sign. Okay. In case of the without sensory sign, I will say on examination of this gentleman, there is a weakness of the both leg where distal is more weak than proximal and extension more weak than flexor. And there is also hypotonia, hyporeflexia, and absent plantar response. Okay. Coordination is not assessed properly due to weakness, and sensory system examination reveals all modalities of sensation is intact. So my diagnosis is the case of flaccid paraparesis without any sensory loss. This is the clinical diagnosis. So what may be the cause? It may be AIDP, that means acute inflammatory demyelinating polyneuropathy, or it may be CIDP, CIDP or AIDP. Most part is acute intermediate porphyria. Again, in porphyria there is a lead cause, porphyria. So lead poisoning, hereditary sensory motor neuropathy, sensory motor neuropathy. Then help say maybe motor radiculopathy. There may be anterior horn cell disease like MND, and there may be a myasthenic event or myotonic dystrophy. But if we see this is a chronic case, there is a blowing of the finger, there are some washing. So just will, in case of blowing of the finger, there is a washing, this cause will come first. That is hereditary and young patient. So that is hereditary sensory motor neuropathy. And case of the CIDP. The CIDP, actually, if there is a possible patient has previous history of GBS, now there is no improvement, it turns into CIDP. So those cause will come earlier. If there is a growing of the finger and there is wasting.
Sir?
Yes?
Sir, in this you said anterior horn cell is MND, yes. And what is the other one, PMA?
Sorry, poliomyelitis. But poliomyelitis is not so common.
Yes.
Okay. Now I'll move to the next. That is a flaccid paraparesis with sensory lesion. So flaccid paraparesis with sensory lesion. Oh, sorry. Regarding the investigation, now in case of the investigation, any investigation that involves the peripheral nerve, I will say the NCS and EMG, NCS and EMG. And here there is a MND, or there may be a myotonic muscle problem. So there is a CPK. I will do the muscle biopsy. I will do the genetic testing, and I will do a specific then like porphyria. I will do a lot of investigation for the porphyria. Yes, lead poisoning. I will do the investigation for the lead poisoning. But first aim is to confirm this is upper motor or lower motor neuron lesion. So, or exclude from the myopathy. So this is the first aim. So NCS, EMG, CPK, muscle biopsy, genetic test. By the test, I will exclude this, or I will establish this is the cause of lower motor neuron lesion. Okay. Then I investigation may be vary for to see any specific thing. Okay. Now I will discuss the flaccid paraparesis with sensory sign. Okay. In case of the flaccid paraparesis with sensory sign, again, what I will say that means by this way I know that this is the case of peripheral neuropathy. Okay. So on examination of the gentleman, there is this will be chronic most of the time, wasting of the leg, growing of the finger, high output, walking it. Or on examination of this gentleman, there is a wasting of the legs. And sometimes I found there are some tropic things. There are some ulcer, there are some skin dry, atrophy, loss of hair, blackening of the skin, all those is tropic things. Okay. So there is a weakness of the leg where distally is more weak than the proximal and extensor are more weak than the flex. And there is also hypotonia, hyporeflexia, and downgoing plantar. And coordination is normal, and sensory system examination reveals is a bilateral, symmetrical loss of all modalities of sensation in stalking pattern. So findings is motor system is flaccid paraparesis and coordination normal. Sensory system examination reveals bilateral symmetrical loss of sensation, all modalities of sensation in stalking pattern. So bilateral symmetrical loss of all modulators of sensation in stalking pattern. So my diagnosis, this is a case of bilateral symmetrical distal sensorimotor neuropathy. This is a clinical diagnosis. So this is a clinical diagnosis is you can say flaccid paraparesis with loss of sensation in stalking pattern, or better to say bilateral symmetrical distal sensorimotor neuropathy. So bilateral symmetrical distal sensorimotor neuropathy. Or a flaccid paraparesis with loss of sensation, loss of all modalities sensation in a stalking pattern. So what is the diagnosis? This is a clinical diagnosis. So main differentiation, this is a case of actually peripheral neuropathy. So peripheral neuropathy, in case it will be, in case of the adult, most of the time I will find patient is adult. I will say number one cause is diabetes mellitus, number one is CKD, then alcohol, then drugs, then vasculitis. See, in case of the young patient, if the patient is young, what I will say hereditary sensory motor neuropathy, vasculitis, that may be primary or secondary, drug cause, paraneoplastic cause, and alcohol. So it will be differ from the patient to patient. So if the patient is young, I will say hereditary sensory motor neuropathy, vasculitis, drug, paraneoplastic. Then in case of adult, diabetes, CKD, alcohol, drug, again paraneoplastic, syndrome, carcinomatous neuropathy. So all those things is a flaccid, could may cause a flaccid peripheral, bilateral, symmetrical, distal sensory motor neuropathy. Okay. So regarding the investigation, here what I will do, I will do again in case of the investigation, I will do NCS and EMG to confirm this is a disease of the nerve problem. This peripheral to confirm this peripheral neuropathy and exclude myopathy, NCS engines. Okay. Now I will do the other specific investigation. Like if we say this is diabetic mellitus, older age, so I will check in case of diabetes. What I will say, blood glucose fasting 2 hours after breakfast plus HbA1c. Fasting 2 hours after breakfast and HbA1c. Okay. In case of alcohol, just I also say alcohol history. Then I can do the CBC to see macrocytosis, liver enzyme. Then in case of the chronic kidney disease, again serum urea, electrolyte and creatinine, urine for routine and microscopy examination, urea clearance test, calcium, alkaline phosphates, parathyroid, vitamin B level. So a lot of investigation. This depends on the other cause. And regarding vasculitis, I'll do say only the vasculitis screening. It may be due to autoimmune test. This may be I will say I will do autoimmune screening. Okay. So now it will examine the how will management again general and specific. General patient education, counseling, explanation of the disease, formation of the multidisciplinary team that involve my consultant, social worker, occupational healthcare, physiotherapist. Then specific management depends on the cause. And here I would say some causes. There is a peripheral neuropathy. There is a pain. I will go. Pain. I will give some drugs. If there is some ulcer, I will give antibiotic, regular dressing, and if there is any pain, I will do the neuropathic pain It is amitriptyline, gabapentin, pregabalin, fluoxetine, just like this. So this is the case of peripheral flaccid paraparesis with sensory lesion, that is peripheral neuropathy. So I have discussed the most of the important cause, that is, I have discussed all cases of spastic paraparesis and all cases of the flaccid case. So today I will not discuss anything more. So I will do this next of the discussion after the 4th class. Okay. Then next day I will do the cardiology. Then I will do, then again in another day we will discuss the other parts of the neurology, because it's a complex thing and it's actually very big thing. And because I have to say the next day how to examine the cranial nerve, I will do the Parkinson disease and the most common case, just like a ptosis, there is a bilateral ptosis. So discussing cranial nerve, how to do the examination, what are the most common cases cranial nerve, that is the next class. So do you have any question?
Sir, I just want to thank you. It was very informative session and really very helpful, sir. Thank you so much.
Thank you. Just no one knows actually whenever he will get chance to give exam, because if his exam is cancelling. So what my advice to you, just prepare yourself up to date for the exam. Okay, just whenever you get the chance, what I think that you pass the first attempt.
Thank you so much, sir.
Dr. Shovan, thank you so much. It was very nice. Actually, I was asking you a question and my net connection got lost in the middle about the crude touch. I wanted to know that is there any condition where crude touch only is lost? Why is it important to check it in the exam? I'm confused about it.
No, we'll just only actually a fine touch, crude touch is a fine touch is comes from the anterior column or and crude touch actually part of the dorsal column. So just our aim is to examine the touch, either it is lost from the anterior side or lost from the posterior or dorsal side. So I will just check the those side which is more specific and reproducible, that is pain. And and in the dorsal, if I want to see what I will check, I will do the vibration first. So if I get enough chance, always I will check the next time. I can check the touch by cotton, or in the posterior I can do the position cells also. First, my aim, at least I will do the pain by neurotip, and I'll check the vibration by I'll check the tuning fork. So I will do this.
So you said fine touch in the anterior and crude in the posterior, right?
Yes, there is some difference there. Yes.
Okay, and with cotton wool we are checking crude touch, right?
No. I don't remember, but it may be due to fine touch.
Okay.
But I will not going to check. It's the light touch. Oh, yes. Cotton is the light touch. Light touch, yes, light touch.
Yes, cotton is the light touch, other one is the pinprick sensation. So both are different in a way that cotton wool sensations, they come from the anterior, and the pinprick, they come from the lateral column. So combined together, that is actually the anterolateral column, which is
Yes.
which we are testing. Yeah.
Yes, thank you. Yes, you are right.
Thank you, doctor. It was very nice session.
Thank you.